Hello, my name is Catherine, and I'm a medical student at the University of Queensland. Today, I'm going to be talking about traumatic cardiac arrest in space. Cardiac arrest is a leading cause of death worldwide and can be further classified as coming from a cardiac cause or a traumatic cause. In accordance with the ensuing variables, cardiac arrest is defined as cessation of cardiac activity and absent signs of circulation. On the other hand, traumatic cardiac arrest is defined as cardiac arrest following a kinetic force excluding cardiac cause, drowning, hanging, electrocution, thermal injury, or drug overdose. For example, if a male with underlying cardiovascular disease is driving down the freeway and has a cardiac arrest from a cardiac source, leading him to lose consciousness and crash into another car, we define this as a cardiac arrest. However, if the same male is driving down the freeway and hit another car, causing a piece of metal from the car to penetrate his chest, leading to severe hemorrhage and cardiac arrest due to hypovolemia, we would consider that to be a traumatic cardiac arrest. Traumatic cardiac arrests not only have different etiologies, but also different contributing factors and outcomes in comparison to arrests from cardiac origin. Traumatic cardiac arrests make up only 6% of all cardiac arrests in Australia. Worldwide, traumatic cardiac arrest has been reported as high as 6 to 7%, where cardiac arrest from a cardiac cause has been reported much higher than that. When looking at the mechanisms of injury for traumatic cardiac arrest here on Earth, motor vehicle crash is by far the most common, followed by penetrating injury and fall from height. Due to lack of gravity and the situational features of a space mission, we would suspect that some of the causes of injury here on Earth would be non-contributory in space. For example, fall from height or gunshot we would not expect to see. Rather, it's thought that the greatest injury in space comes from blunt or penetrating trauma during an extra-vehicle activity. While there are many different ways we can measure the outcomes following a traumatic cardiac arrest, such as return of spontaneous circulation, GCS, neurological function, or even just return to Earth, the ultimate goal of treatment for the patient is to survive and survive with a good quality of life. Research over the past decades have worked to identify features associated with better outcomes here on Earth in an attempt to maximize good patient outcomes. They found that things such as a short transport time to hospital and low injury severity score can result in better chances of survival. While to date there have been no recorded traumatic cardiac arrests in space, considering the incidence and associated mortality here on Earth, it's of the utmost importance that there's a plan in place if and when such an event occurs in space. While astronauts are thoroughly medically screened before flight to minimize any underlying conditions causing a medical emergency, the nature of trauma is that it's often due to extrinsic causes rather than a person's health. Furthermore, with the shift that we have been seeing towards civilian travel, everyone may not go through such vigorous screening that astronauts do today. The three main components of management of a traumatic cardiac arrest include treatment of the reversible causes, basic and advanced life support, and transport to a local hospital quickly. 2016, the protocol for traumatic cardiac arrest management was updated by the Australian and New Zealand Resuscitation Council. In this update, we saw a shift in the management from a focus on a skip and go method of getting patients to the hospital as soon as possible to the treatment of reversible causes. The three main causes identified as reversible and causing traumatic cardiac arrest include airway obstruction, tension pneumothorax, and hemorrhage. If a patient's airway is obstructed, theoretically, it's been shown that intubation can be placed in space. However, even a trained professional may have difficulty doing it in the environment. So based off of the training of the people on the crew and the materials available, a different airway tool may need to be placed. A tension pneumothorax may be very difficult to identify in the loud environment of a spacecraft. However, ultrasound may assist in this process. For the treatment of a pneumothorax, once it's been identified, both needle and tube thoracotomies have been successfully performed during parabolic flight. Hemodynamic physiology is different in microgravity, adding an additional layer of complexity to the treatment of hemorrhage in space. To identify a bleed, fast scans have been shown to be feasible to complete. Furthermore, IV infusions are possible, although there's often a limited amount of fluids or colloids on board to give for fluid therapy. Tourniquets or direct pressure may be applied, but both of these are only a temporary fix. For intra-abdominal bleed sources, surgery may be required to control bleeds. While I'm not going to dive too far into the surgical perspectives in space, there is another speaker talking on that in the conference, and I'd highly recommend checking out their talk for more information. In addition to the treatment of reversible causes, basic and advanced life support are central to the resuscitation of a traumatic cardiac arrest. A key component of that is chest compressions. In a microgravity environment, you're not able to lean over a human with hands on their chest as you might have been taught in a basic life support class or maybe even saw in a television show. Upon doing that in a microgravity environment, both bodies would travel in opposite directions due to the pressure added. Therefore, various researchers have come up with methods to provide chest compressions in a microgravity environment. To date, there's been 5 listed methods in which this can occur. There's 2 methods that use a restrained setup, one of which is a standard side saddle, and the other of which is a waist straddle. Both of these options require a patient provider to be strapped into the vehicle. Another option is a reverse bear hug method. On top of that, there's a handstand method and the Yvette's-Brusimo method. Each of these 5 different methods have unique advantages and disadvantages. For example, the handstand method requires that the provider reach their feet on one end of the vehicle while putting their hands on the patient on the other end. By doing a squat-like motion, they're able to provide the compressions to the patient. While this gives the deepest and most best quality compressions of all of the methods, it requires a very specific environment and therefore may be challenging and not always available. Available adrenaline may be very easy to administer to a patient. However, some research has shown that the effectiveness of epinephrine may be altered by microgravity. Another key component of advanced and basic life support is defibrillation. While defib is very possible, the patient must be on a safe service to actually administer the shock. If not, the conductance might travel to other parts of the aircraft, harming other members of the crew or damaging the electrical functions of said aircraft. It's also important for the primary provider of the basic or advanced life support to consider the 4 H's and 4 T's. These include hypoxemia, hypovolemia, hyper or hypokalemia, hypo or hyperthermia, and then the 4 T's, tension pneumothorax, which we've talked about in the reversible causes, tamponade, toxins, and thrombosis. All of these should be considered as possible contributors to the current arrest. After any arrest on Earth, a key component to the chain of survival is rapid transport to a nearby hospital. However, how feasible is this in space? Well, it can take up to 45 days to execute a low orbit evacuation. During such an evacuation, fluid shifts, vasoconstriction, and other physiological shifts may make it very difficult to maintain hemodynamic stability of a post-traumatic cardiac arrest patient. If we think about missions farther out, transport back to Earth hospital might be out of the question altogether. If a patient post-traumatic cardiac arrest and after arrest stays in space, there can be some additional challenges to the healing process. For instance, we know that fractured bones take more time to heal in space and microgravity. Additionally, microorganisms appear to have higher virulence and antibiotic resistance in space. This could lead to some serious and life-threatening complications, such as post-arrest sepsis, if a thoracotomy or other invasive procedure was performed. In conclusion, the austere microgravity environment of space makes it a unique environment to treat patients with traumatic cardiac arrest. Research into the treatment methods in parabolic flights has provided valuable insights to the feasibility of different treatments. However, all the potential treatment options require different materials, and the size, weight, and physical space of each will need to be taken into account when making decisions about what will be on board. Thorough training of multiple crew members will allow multiple responders to assist in the resuscitation and the completion of complex management. While governing bodies on Earth has provided guidelines on traumatic cardiac arrest in city and austere environments, guidelines with feasible management options designed for a microgravity environment are required. Such guidelines will need to consider not only effective treatment of the patient, but also at what point management is futile and is only putting other crew members at risk by providing care to a patient in which resuscitation is not achievable. Here are the references for the research I referred to throughout the talk if you want to read more about it. And if you have any questions or comments, don't hesitate to reach out. I'd love to hear from you. Thanks for listening, and I hope you enjoy the rest of the conference.